Let's solve another challenging case. Challenging case 54 was really challenging. Young male patient presented with sudden painless loss of vision in one eye. Vision in the affected eye was 612, whereas other eye had got 6:6 vision. Intraocular pressure was normal, anterior segment was normal in both eyes. One eye fundus was absolutely normal and the other affected eye fundus is shown. If you look at the fundus, instantly it looks like a straightforward case of central retinal vein occlusion. You can see the edematous disc, hemorrhages around the disc, but the hemorrhages are not typically flame shaped and covering the whole macula. Macula is spared and vision is also not that much decreased as compared to the fundus signs. Now look closely, the site of pathology is optic disc. All the disease is surrounding the center optic disc. Optic disc is raised, engorged, edematous, congested, and vessels arising from it are also engorged, but for a short distance. As you go away little bit from the optic disc, the signs suddenly disappear, the macula is spared, unlike central retinal vein occlusion, and fundus is not full of flame shaped hemorrhages. So, it is not a full blown central retinal vein occlusion. Another differential could be papillitis, but in papillitis there should be relative afferent pupillary defect positive, color desaturation, light brightness, contrast should be affected, and retinal vessels should not be engorged. And so it's also not a case of optic neuritis because these findings are absent. Now another differential could be malignant hypertension, but in that case we should have bilateral swollen optic discs and high blood pressure. Blood pressure was normal. The next could be papilledema. Again you will get bilateral swollen discs and normal vision, but vision is slightly reduced and it is not a bilateral condition. Then we can think of diabetic papillopathy, but findings are again unilateral and the patient is non-diabetic. So we diagnosed him as a case of papillophlebitis. Few comments were spot on. They diagnosed it as a case of papillophlebitis. It is a subtype of central retinal vein occlusion, but it differs as cause of venous insufficiency is presumed to be central retinal vein inflammation at the optic nerve. It occurs in a young adult, mostly females with no history of vascular disease. There is inflammation of the optic disc leading to compression of the central retinal vein, and venous insufficiency is the underlying mechanism. So, painless unilateral disc edema, hyperemia, retinal venous engorgement near optic disc, and variable extent of intraretinal hemorrhages in an otherwise healthy adult. Vision is considerably better as compared to the retinal findings despite significant optic disc edema and venous engorgement. Vision in this patient was near normal. There is no macular edema. If not diagnosed and treated immediately, it can lead to traditional central retinal vein occlusion with poor vision and macular edema. Causes are hypertension, diabetes, hematologic disorders, dehydration, inflammatory bowel syndrome, oral contraceptive pill use, almost similar to vein occlusion. OCT is normal. Systemic and periocular steroids are the mainstay of treatment in order to avoid it becoming a full-blown central retinal vein occlusion. So it was an interesting case of papillophlebitis, a classical papillophlebitis case that I shared. Thank you very much.